Immunology Insights, Basics and Beyond, Chapter 33, Rheumatoid Arthritis, Chronic Inflammation and Joint Damage. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our previous chapter, we learned about lupus erythematosus, a prototypical autoimmune disease with diverse symptoms and systemic involvement. Today, we are discussing another important example, rheumatoid arthritis, or RA, a chronic autoimmune disease characterized by persistent inflammation and joint damage. So let's talk science. What is actually rheumatoid arthritis? Well, RA is a chronic autoimmune disease primarily affecting the synovial joints, including the hands, wrists, and knees. It is characterized by chronic synovitis, leading to pain, swelling, and eventually joint destruction. RA is commonly associated with autoantibodies such as the rheumatoid factor, or RF, an antibody that targets the Fc region of IgG, forming immune complexes. Then anti-citrullinated protein antibodies, or ACPAs. They target proteins modified by citrullination, a process where the amino acid arginine is converted to citrulline. These autoantibodies play a central role in the pathogenesis of RA, promoting inflammation and tissue damage. RA can vary in severity from mild joint discomfort to severe disability due to joint deformity. Let's look at the pathophysiology of RA. Rheumatoid arthritis involves a complex interplay between genetic predisposition, environmental triggers, and immune dysregulation. First, we have the synovial inflammation. The synovial membrane lining the joints becomes inflamed due to immune cell infiltration, including T cells, B cells, and macrophages. Activated dendritic cells present antigens to T cells, triggering an inflammatory cascade. Second, pannus formation. Chronic inflammation leads to the formation of pannus, an invasive granulation tissue that erodes cartilage and bones. The pannus contains fibroblasts, macrophages, and osteoclasts, which release proteolytic enzymes like matrix metalloproteinases, or MMPs, that degrade the cartilage. And third, we have of course cytokine involvement. Pro-inflammatory cytokines, particularly TNF-alpha, IL-6, and IL-1, perpetuate inflammation and joint damage. TNF-alpha stimulates the production of other cytokines and chemokines, while IL-6 promotes B-cell activation and autoantibody production. RA is also characterized by the formation of immune complexes in synovial fluid, further activating the complement system and perpetuating tissue damage. There are also genetic and environmental factors involved. As for the genetic factors, the HLA-DR4 allele is strongly linked to rheumatoid arthritis susceptibility. HLA-DR4 molecules present citrullinated peptides to T cells, leading to the activation of autoreactive lymphocytes. Additionally, polymorphisms in genes like PTPN22 and STAT4 can impair immune regulation. Then we have the environmental factors. Smoking is a major environmental risk factor, increasing the risk of developing ACPAs. Smoking induces citrullination of proteins in the lungs, promoting the formation of autoantibodies. Besides smoking, also infections contribute to the environmental factors. They can also act as triggers by activating pattern recognition receptors, so PRRs, leading to persistent immune activation even after the infection is cleared. Additionally, hormonal influences may explain why RA is more common in women, particularly during or after menopause. But how is RA diagnosed? Rheumatoid arthritis diagnosis relies on a combination of clinical assessment, imaging, and serological testing. First, the serological markers. Rheumatoid factor, or RF, is positive in about 70 to 80% of RA cases, but not specific. Then we have anti-CCP, so cyclic citrullinated peptide. This is highly specific for RA, detected in early disease stages. Second, imaging studies. Of course, X-rays that show joint spaces narrowing and erosions. and then MRI and ultrasound. They detect synovitis and early erosive changes. Third, we have clinical features. Symmetrical joint involvement, morning stiffness, lasting over an hour, and soft tissue swelling are all clinical symptoms associated with RA. When it comes to the treatment, RA management aims to reduce inflammation, prevent the joint damage, and maintain function. First, we have disease-modifying antirheumatic drugs, or DMARDs. There is methotrexate, which inhibits dihydrofolate reductase, reducing lymphocyte proliferation. And there is leflunomide, which inhibits pyrimidine synthesis, decreasing T-cell responses. Second, we have biological agents, like TNF inhibitors, for example adalimumab, which blocks TNF-alpha, reducing synovial inflammation. Then we have IL-6 receptor antagonists, like tocilizumab, which decreases IL-6 mediated inflammation. And we have, of course, B-cell depleting agents, for example rituximab, which reduces autoantibody production by targeting CD20. And third, we have physical therapy and lifestyle adjustments. Regular exercise helps maintain joint mobility. Smoking cessation is crucial to reduce flare-ups, and occupational therapy can support patients in maintaining daily functions despite the joint damage. To conclude, rheumatoid arthritis exemplifies how chronic inflammation leads to progressive joint damage and disability if not treated promptly. As one of the most common autoimmune diseases, RA serves as a model for understanding chronic autoimmune inflammation. Early diagnosis and intervention with DMARDs and biologics is essential to slowing down disease progression, as is physical therapy and lifestyle adjustment. Understanding RA not only helps to managing joint-specific autoimmunity, but also provides insights into immune-mediated chronic inflammation more broadly. In the next chapter, we will examine the last example of autoimmune diseases, type 1 diabetes, autoimmunity, and insulin deficiency. Before closing, I have a small request. If you enjoyed my content and want to hear more, like and subscribe. It's a small step for you, but it helps me a lot. So see you next time and thank you for listening.